epilepsy education. We see quite a large number of patients with convulsions of different etiologies coming to KNH. So we thought that it would be prudent for everybody who comes into contact with a convulsing child to have some basic education on what to expect. With me, as has been said, is Sister Joan Kagema. She's an pulmonology nurse with an interest in epilepsy, and Dr. Anne Kamunya, who's a consultant pediatric neurologist. So, as an introduction, epilepsy is a common disorder with an estimated prevalence of about 1%. Majority of the patients who present in KNH, Pediatric Neurology Clinic, actually have epilepsy of varying etiologies. Some have cerebral palsy, some have epilepsy due to post-meningitic sequelae, various etiologies. Children and young people with epilepsy are usually poorly integrated, less accepted, and more likely to be isolated. Some of the challenging aspects of management of these epileptic patients are, number one, they have multiple comorbidities. You'll find a patient with epilepsy would also have autism spectrum disorder, ADHD, intellectual disturbances, among other comorbidities. Also, we know that in pediatric patients, the brain is still maturing. So we have many changes that are going on in the brain as opposed to an adult who has already reached full maturity of the brain. And we have many sociocultural issues that affect the management of epilepsy patients. We find in our society, there are strong cultural beliefs. Many people would believe that epilepsy has been brought by some bad demons. Actually, if you come into the pediatric neurology clinic, you'll find many of the mothers are single mothers. They always come alone to the clinic. You rarely see the men accompanying because many of these men feel that it's the woman's fault, or sometimes they even abandon the woman. So the woman is left raising a child who has epilepsy on her own, and she ends up with so many challenges. Management of epilepsy is actually very dynamic and an individualized process. One size does not fit all. Just because you see one epilepsy patient doesn't mean that you use the same treatment for all of them. You actually have to look at each of them as an individual and tailor the medication appropriately based on the patient's history and physical examination. So before we dive into epilepsy, let's remind ourselves a little bit about the neuroanatomy of the brain and the spinal cord. We know that for communication to take place in the brain, this usually occurs through neurons. Neurons consist of a cell body, an axon, and an axonal terminal end, which usually synapses with another neuron. So this axon is usually myelinated, and this is where transmission usually occurs once a signal enters the neuron. So in response to a signal, the soma end of the axon usually becomes depolarized. We have influx of sodium into the neuron, and the depolarization travels down the neuron. And this is how a message usually passes from one neuron to another. So once depolarization occurs, immediately we have a repolarization of the region that has been depolarized. So this is just expounding on that. So we have a signal that passes into the brain through the neurons, and it activates the neuron, and the action potential usually travels down this axon and arrives at the presynaptic end of this neuron. So once it arrives at this presynaptic end, we say that the action potential occurs when we have influx of sodium. So this influx of sodium into this presynaptic end will cause voltage-gated calcium channels to open at the axonal terminal. So when these calcium channels open, there's influx of calcium from the synaptic cleft into this presynaptic neuron. The calcium influx will force these synaptic vesicles, which contain neurotransmitters, to come onto the axonal terminal, and they will fuse with the cell membrane and will have release of this neurotransmitter. Now, this neurotransmitter can be an excitatory neurotransmitter or an inhibitory neurotransmitter. So if we have an excitatory neurotransmitter released here, it will bind onto the receptor on the postsynaptic neuron. And if it's excitatory, for example, glutamate, it will activate this neuron. So you can imagine in a case of epilepsy, we have excessive firing of this presynaptic neuron, and it will go and activate the next postsynaptic neuron. And basically that is how a seizure usually occurs. So these are definitions from the International League Against Epilepsy. A seizure is a transient occurrence of signs and symptoms due to abnormal, excessive, or hyposynchronous neuronal activity in the brain. And we can understand this if we go to the previous slide and we see how the axons usually fire. So we have a seizure, and then we have what we call epilepsy. Epilepsy is defined as one of the following: when you have at least 2 unprovoked seizures occurring more than 24 hours apart. So according to the International League Against Epilepsy, if you have, let's say, 5 seizures occurring within 5 hours, according to this classification, they will be considered as one. Epilepsy only occurs if we have 2 of these seizures occurring more than 24 hours apart. The second definition of epilepsy is when you have 1 unprovoked seizure and a probability of a further seizure due to heightened risk of at least an estimate of about 60% over the next 10 years. And the third definition of epilepsy is when you have an epilepsy syndrome, which we will define later. But examples of epilepsy syndromes would be West syndrome, Dravet syndrome, or Lennox-Gastaut syndrome. This usually occurs when you have characteristic clinical and EEG features that define this syndrome. So how do we classify epilepsy? And we'll go into detail of these classifications. We can have a seizure occurring as a focal onset seizure, generalized onset, or unknown onset. So when we have a focal seizure, it can come with or without awareness, and then it can be motor or it can be non-motor. When we have a generalized seizure, again, it can be a motor or a non-motor seizure. And then we have unknown onset. Unknown onset occurs when nobody has witnessed the beginning of the seizure. So you can't really explain how the seizure began. Again, it can also be motor or non-motor. And I will explain each of these. So for classification of seizures, we've said we classify number 1 according to the type of onset. We can have a focal seizure. So when we have a focal seizure, it originates within networks limited to one hemisphere. Then we can have a generalized seizure, which originates at some point within the brain and rapidly engages bilateral distributed networks. And as I mentioned, we can also have a known type of onset of seizure when nobody has witnessed. Then a further classification would be the level of awareness of self or surroundings for the focal seizures. So focal seizure can be with impaired awareness or with retained awareness. What this basically means is you may be having a seizure and you're actually aware that the seizure is occurring, or you may have loss of awareness. Now, level of awareness is not usually used for generalized seizures because majority of them have impaired awareness. So further classification of seizures would be motor versus non-motor seizures. So for the motor seizures, we can have what we call a tonic seizure. A tonic seizure is when you have a sustained focal stiffening of the limb. A clonic seizure occurs when you have rhythmic jerking movement of the limbs. So most of us, when we think of epilepsy or seizures, we think of tonic-clonic seizures, which are characterized by stiffening and rhythmic jerking of the limbs, as you can see in this diagram. But it is important to know that there are other types of seizures. So don't just think of a seizure as somebody who's having a generalized tonic-clonic seizure. We have what we call myoclonic seizures, which are irregular, brief, jerking, shock-like seizures. Now, what is the difference between clonic and myoclonic seizures? A clonic seizure usually implies sustained, regularly spaced stereotypic jerks, whereas myoclonus usually are less regular and in briefer runs. So I'm going to play this video for you, and I'd like you to just quickly type in the chat box what kind of seizure you think this is. Anyone would like to hazard a guess what kind of seizure this is? Okay, so this is a myoclonic seizure. You can see brief, jerky movement of the limbs. Let me just play that one more time. So that is a myoclonic seizure. Then further down, we have what we call epileptic spasms. These are sudden flexion or extension of the arms and flexion of the trunk. We have what we call atonic seizures, which we have sudden loss of tone involving the limb, the trunk, the head, or the jaw. And these patients with atonic seizures would commonly present with multiple injuries because they just suddenly lose power of the tone and they tend to fall. So you'll actually notice that they have lots of cuts and healing wounds on the head or on the rest of the body. Then we have what we call hyperkinetic seizures, where patients present with pedaling or thrashing activity. Then we have what we call automatism, which are purposeless, repetitive motor activity. For example, you may see a patient just smacking the lips continuously or having an unusual chewing movement. So I'll play this video again, and you can just quickly type in the chat box what type of seizure you think this patient is having. Sorry. Anyone?
There's nothing in the chat as yet. Still waiting.
So this patient is having epileptic spasms. We see that we have sudden brief flexion of the arms and flexion of the head. So you can see that you have to actually note the subtle difference in the different types of seizures that present in patients. I'll play another video and I'd like you to tell me what kind of seizure you think this patient is having. Great, I can see some people got the previous video. They knew that there were epileptic spasms. So I'll just play this video now. So you can see an infant who's being fed by the mother and they have a sudden drop of the head.
Someone says atonic seizure. Atonic.
Fantastic. Fantastic, yes. So this patient is having atonic seizures. So this is just to emphasize that for us, a lot of times we're just used to seeing generalized tonic-clonic seizures. So if you have your infant who's presenting to you with a sudden drop of the head, unless you're aware that there are different types of seizures, you may actually end up missing out on this and you end up finding that your patient is deteriorating. So we'll now move on to focal non-motor seizures. We have what we call autonomic seizures. This is a distinct alteration in the autonomic nervous system functioning involving either the cardiovascular, pupillary, GI, pseudomotor, vasomotor, and thermoregulatory functions. For example, this patient may have GI sensations, like they may complain of some extreme nausea, extreme desire to vomit. They may have a sense of heat or cold. They may have flashing of the face, piloerection, which is goosebumps, sudden palpitations, or they may get respiratory changes. Again, this just emphasizes if you're not aware that you can have autonomic seizure and you have your patient presenting to you and complaining that they're always having, goosebumps in the hand, or they're always having flashing, then you may not be able to recognize that this is a type of seizure. We have also behavior arrest seizures, where we have arrest or pause in activity. So the patient has cessation of movement and suddenly becomes unresponsive. For example, you can be having a conversation and then the patient just suddenly freezes and then after some time continues with the activities. We have what we call cognitive seizures, where the patient has a sudden deficit in language, in thinking, or higher cortical functions, such as a feeling of déjà vu or hallucinations. Then we have emotional seizures. These are seizures presenting with an emotion or the appearance of having an emotion as a nearly prominent feature. For example, we have what we call gelastic seizures, where you just find a patient who comes and is just continuously laughing and laughing. You know, there's no joke that has been cracked, and the parents are saying, this, my son is always just, you know, he just suddenly bursts out laughing. Or we have what we call dicrastic seizures, where the patient presents with crying. They may present with a sudden sense of fear or doom. So these are examples of emotional seizures. Now, for the generalized non-motor seizures, we have what we call absence seizures. So an absence seizure can be classified as either typical or atypical. Now, a typical seizure is a sudden onset interruption of ongoing activities, a blank stare with sometimes upward deviation of the eyes. Usually the patient will be unresponsive when spoken to, and it lasts just a few seconds, less than 30 seconds, with a rapid recovery. Absent seizures are not equal to blank stares, and when you actually do an EEG on a patient with an absent seizure, it will show generalized epileptiform activity. We had actually a patient come into the pediatric neurology clinic, and the main complaint of the mother was, she said that in school, the teacher was complaining that the patient seems anazuba tu kila wakati briefly, and then suddenly, you know, gets back to the activities of the class. And the mom was like, even her, she's noticed that at home, she's talking to the son, and then he seems to just have a blank stare. She tries to call him, he does not respond. And then after a few minutes, he's back to what he was doing. Then we have atypical absence seizures. Now, an atypical absence seizure, usually you'll have sudden changes in tone that are more pronounced than an atypical absence seizure, or the onset and or cessation is not as abrupt as the typical absence seizures. So this would usually be a generalized seizure, and there will be loss of awareness. So I'll just play this video for you, and I'd like you to quickly type in the chat box what you think this patient is having. Sorry. I hope you noticed that. I hope you saw that.
Nothing in the chat yet.
So anyone, I can see some answers. Yes, I can see
Generalized
someone has said
absence.
yes, generalized absence. So we've said absence can be typical or atypical. What do you think this patient is having? Is it typical or atypical?
Atypical. Someone says atypical absence.
Typical. It is typical.
Oh, okay.
It is typical. Let me go back. So we said typical is a sudden onset interruption of ongoing activities, a blank stare with sometimes upward deviation of the eyes, which we saw in our patient. And usually the patient will be unresponsive when spoken to. It lasts very few seconds with a very rapid recovery. We can see our patient was actually able to go back to what she was doing. She just had a blank stare briefly and then was unresponsive and then went back to what she was doing. And then we said for the atypical ones, then they don't really fit into the definition of typical, and usually the onset and or cessation is not as abrupt. So, so more about the non-motor absence seizures, we also have what you call eyelid myoclonia, which are myoclonic jerks of the eyelid and an upward deviation of the eyes, often precipitated by closing the eyes or by light. It can be associated with absences, but also can be motor seizure without a corresponding absence. Okay, and then we have what we call myoclonic absences. Remember the video that I played of the myoclonic jacks? So in myoclonic absences, the patient has a myoclonic seizure with loss of awareness. So going back to this classification of seizures, I hope this has made it easier to understand. I'll just go over this again. We can have a generalized onset seizure or a focal onset. Generalized involves both hemispheres of the brain. It can be motor or non-motor. Motor can be tonic, clonic, tonic-clonic, myoclonic, or you can even have a combination of all. You can have atonic and epileptic spasms. Non-motor is absent. It can be typical, atypical, myoclonic absence, or eyelid myoclonia. For the focal onset, the first thing you need to check if there's awareness or if there's impaired awareness. Then you want to see if there's motor involvement. Automatism, we said, is like lip smacking or chewing. Atonic, sudden loss of tone. It can be clonic, epileptic spasms, hyperkinetic, myoclonic, or tonic. Non-motor, we have autonomic, involvement of the autonomic nervous system, behavior arrest, cognitive, emotional, or sensory. And then unknown onset is when it's not witnessed, and it can be either generalized, focal, it can be motor, non-motor, or just unclassified. So it's important to know that just because a patient is shaking does not mean that this patient is having a seizure. There are very many seizure mimics, and it is important for us as clinicians to be able to recognize that what you're seeing may not actually be a seizure. For example, in the neonatal period, a sick child may be having an apneic episode, and you end up thinking this is an absence. We have what we call hypereplexia, which is excessive, exaggerated startle reflex. You know, the way like sometimes the baby shakes when the door is banged. So they have, that is hypereplexia. We can have jitteriness, pain disorders. We have what we call benign neonatal sleep myoclonus. This is something that is often thought to be seizures by new parents, where when your child is asleep, you may notice that the limbs are shaking. Again, in the infant period, they can have things like reflex anoxic seizures. This usually occurs, like, for example, if a child is playing and bangs the head against a wall, the child can actually have what resembles a seizure. We have breath holding spells. Basically, we have so many things that can resemble seizures. Then we have what we call, it's important to also note something called Sandifer syndrome. Sandifer syndrome occurs in patients who have severe reflux disease. So they tend to have what looks like an opisthotonous posturing, and you'll find that they are quite stiff. And if you're not aware, you may actually think that this patient is having a seizure. In children or adolescents, something important to note is we have commonly children with somatoform disorders. They may have what looks like a seizure, but if you take an adequate history, you may find that it's not. Syncope, thing that is like fainting, hyperventilation spells, drug reactions, masturbation, malingering. So there are so many things that can be mistaken for a seizure. Daydreaming also commonly occurs in children and adolescents, and sometimes you can actually think that if you're aware of what an absent seizure is, you may think that your child is having an absent seizure when he's actually daydreaming. We have a lot of sleep disorders that occur, such as narcolepsy, which is excessive. A patient, for example, has excessive emotional stimuli, like they may be laughing at a joke cracked, and they suddenly fall asleep. So you must be aware of all these seizure mimics as you see your patient. Now, we spoke about epilepsy syndromes as one of the definitions of epilepsy. An epilepsy syndrome refers to a cluster of features incorporating seizure types, EEG, and imaging features that tend to occur together. They're often age-dependent. For example, age of onset and remission, the seizure triggers, the diurnal variation, and sometimes the prognosis. They may have distinctive comorbidities such as intellectual and psychiatric dysfunction. It may have associated etiology, prognosis, and treatment implications. There are many well-recognized syndromes, such as West syndrome, which commonly occurs in the infantile period, childhood absence seizures, and Dravet syndrome. Dravet syndrome is usually what we call a channelopathy, when you have a mutation in the sodium channels, and these patients, sometimes they may present with recurrent febrile seizures. So if you find a patient having recurrent febrile seizures, they may actually be having Dravet syndrome. So this is just a diagram to show you some of the epilepsy syndromes that can occur. We said they're usually age dependent. I will not go through all this. This is just to help raise awareness that we have epilepsy syndromes. And why this is important is that when we come to therapy, sometimes some treatments are worsened, some specific syndromes are worsened by certain anticonvulsants, while some respond better to certain anticonvulsants. For example, neonates who have West syndrome tend to do better with vigabatrin, prednisolone as the first choice of anticonvulsant medication. So going into the etiology of epilepsy. Now, traditionally, we've defined epilepsy as, when we don't know the etiology, we call it idiopathic. But a lot of studies have been done in the Western country, and what they've come to realize that many of these epilepsy syndromes that we call idiopathic actually have a genetic basis. We have a lot of mutations that occur on genes which predispose these patients to having epilepsy. So they're actually not idiopathic, but they have a genetic origin. And we can see from here, apart from having this large group of people who have epilepsy due to genetic mutations in the European countries, other things like trauma, stroke, neoplasms, infections, congenital lesions, and birth asphyxia are causes of epilepsy. We see also that now it's being commonly recognized that things like autoimmune disorders can cause epilepsy. Actually, we have a patient currently in one of the pediatric wards who we diagnosed recently with anti-NMDA receptor encephalitis. And this patient came in with status epilepticus. So if you're not aware of this, you may just treat this patient as meningitis when they actually have an autoimmune basis. Then we also have focal epilepsy with MRI detectable lesions, such as patients who have cortical dysplasia or some sort of lesion on the MRI, which would predispose them to epilepsy. And this is a study that has been done largely in European countries. There was a study done in Cape Town, South Africa, and what they found as the main causes of the acute convulsive episode in children would be genetic, metabolic, and structural causes, accounting for 67%. High on the list for us was also CNS infections, such as meningitis, TB meningitis, HIV, head trauma. We know that road traffic accidents, fall from height are quite common in our setting. Perinatal insults, we know that birth asphyxia accounts for a large group of causes of epilepsy in our patients. And we have other causes such as sickle cell disease, which is prominent in our setting, stroke, and also alcohol. So how do we manage seizures? So the general principles of management of seizures are maintenance of the ABCs, that is airway, breathing, and circulation. If you have a patient coming in with convulsions, you must first of all ensure that the airway is patent, because we know that when you're having a seizure, the tongue can fall back, you may have objects in your mouth. Breathing, always start them on oxygen. And circulation, you must quickly establish IV access, do your glucose levels, do your electrolytes in these patients, so that if you need to administer any drugs, you can rapidly administer. The next principle is termination of the seizure and prevention of recurrence, because we know that seizures are a hypoxic event and they can cause damage to the brain. Then, once we've terminated the seizure, we need to think about diagnosis and initiation of therapy for life-threatening causes such as hypocalcemia, meningitis, or if it is a space-occupying lesion. Then you need to arrange for appropriate referral for ongoing care. This is if you're in a peripheral facility, and management of refractory status epilepticus by involving the pediatric neurologist. So this is a diagram just showing you the principles of diagnosing epilepsy. Remember the definition, we said those three things that would classify a patient as epileptic. I know one of the problems we've had in our KNH Neuro Clinic is sometimes you find a patient coming with a one-time seizure. They've been seen in the pediatric emergency unit, and whoever sees them immediately initiates this patient on an anti-epileptic medication. But this actually needs to be a discussion, because we know that these patients need to be on the anti-epileptic medication for a very long time. We need to think about the diagnosis. We need to think about the side effects of the drugs. We need to think about the social and financial aspects of this patient so that we have appropriate management of our patients. So how do we diagnose epilepsy? You need to do a thorough physical examination. You need to do your neurological examination, although it's good to admit that sometimes if the seizure occurred at home, you may actually find that your neurological examination is normal. Then you need to do your blood tests. This would involve doing your septic screen if you're thinking of an infection, your glucose, which can be done bedside, and other tests will be guided by what you think this patient is having. In the Western countries, they do a lot of genetic testing, which aids in the diagnosis of epilepsy. ECGs are very important also in your patients with epilepsy. So try and do an ECG for all patients who present with the first time seizure, because we know things like prolonged QT syndrome can actually cause a seizure mimic. They can have something that looks like a seizure, and also just to be holistic in the management of your patient. EEGs would also be important for your patient. Now, according to the International League Against Epilepsy, EEGs should be done when your patient has a second unprovoked seizure rather than doing it during the first seizure. Imaging tests would be guided by the patient's diagnosis. We do not standard do MRIs or CT scans for all patients who we suspect to have epilepsy, unless, for example, you think maybe the patient has a space-occupying lesion or has an acute bleed, then you do your MRI or your CT scan. Or if you think that there's some kind of focal injury that this patient may be having, and then that would warrant you doing your MRI. MEGs are magnetic encephalogram. They're not done in our setting, so I will not focus too much on that. So diagnosing epilepsy, again, relies on good physical examination, neurological examination, and the rest of the ancillary tests would be supportive. So we'll now discuss anti-seizure medication. And before we do, we'll just remind ourselves again how a transmission usually occurs in a neuron. We said we have our action potential. So when you have your action potential, what happens is, so first of all, we have our neurotransmitters that are synthesized and stored in the vesicles within the neuron. So when an action potential is fired, we have sodium influx into the neuron, and we have depolarization. When depolarization occurs, depolarization at the presynaptic terminal causes opening of the calcium channels. We have influx of calcium into the presynaptic neuron, and this influx of calcium will then cause release of the neurotransmitters that are stored within the synaptic vesicles by causing fusion. So we have exocyte fusion with the cell membrane. We have exostosis and release of these neurotransmitters, which then bind on the receptor on the postsynaptic neuron. We said that they can be excitatory or inhibitory neurotransmitters. Inhibitory would be something like GABA, excitatory would be something like glutamate. So once these neurotransmitters activate the postsynaptic neuron, they're taken back into the cell for reuse. So how do we classify our anticonvulsants? So we classify them based on where they work. So thinking about how an action potential works, we said when we have an action potential, we have influx of sodium into the cell. So if we want to stop our neurons from firing rapidly, we can actually block this sodium channel. And this blocking of sodium channel, which is voltage gated, is done by drugs such as phenytoin, carbamazepine, oxycarbamazepine, lamotrigine, lacosamide, and zonisamide. And we know many of these drugs are available in our setting. Now, once the action potential occurs, another way you can prevent a seizure is preventing release of this neurotransmitter that is stored within this vesicle. We have drugs such as levetiracetam and brivaracetam, which usually prevent the release of this neurotransmitter by binding on a receptor within this vesicle. And if it prevents the release of the glutamate, then we know that the postsynaptic neuron will not be activated. Now, we say that calcium influx usually causes release of this neurotransmitter. So if we have a drug that blocks the influx of calcium into the neurotransmitter, then we can arrest this seizure. And drugs such as ethosuximide will do this. Now we have what we call potassium channels. Usually, when a neuron fires, we have an action potential. We say there's influx of sodium, but this cell actually has to repolarize. So repolarization occurs when the potassium channel opens and it causes release of potassium out of the cell. So if you want to promote rapid repolarization, then you can get a drug that forces these potassium channels to open, and we have rapid repolarization of the cell, thereby arresting the convulsion. And a drug like retigabine would do this. We said that for the action potential to be transmitted, we have to have opening of our sodium channels. And examples of sodium channels are AMPA and NMDA. So AMPA and NMDA can actually be blocked by drugs such as sodium valproate and topiramate, thereby arresting our convulsions. Now, moving on to the inhibitory synapse. If we have drugs that encourage the release of the inhibitory neurotransmitter GABA, then this will inhibit the transmission of the neuron from firing excessively. Drugs such as the benzodiazepines, barbiturates such as phenobarbital, topiramate, and stiripentol actually encourage the binding of GABA on the postsynaptic neurotransmitters. So it will cause inhibitory signals, thereby arresting the convulsion. Similarly, we have sodium valproate and vigabatrin, which usually work by preventing the breakdown of GABA. So if they prevent the breakdown of GABA once it has bound onto this receptor, we'll have a lot of GABA on our synaptic cleft. And this GABA is able to activate more of the GABA receptors, thereby arresting the convulsion. And retigabine we have already spoken about. So basically that is how our anticonvulsants usually work. So what anti-seizure medication should you use when presented with a convulsing patient? We have our first generation anticonvulsants, which have traditionally been very available, such as phenobarbital, phenytoin, sodium valproate, diazepam, which we are all familiar with. But and most of these ones were produced before 1993. However, we have also our second generation anticonvulsants, which came about around 1993 to 2005. They tend to work better, such as the levetiracetam, lamotrigine, tiagabine, pregabalin. And then we have our third generation anticonvulsants, which are new onto the market, such as brivaracetam, stiripentol, and rufinamide. So I know traditionally many of us, we've worked with this first generation anticonvulsants, but it is good to be aware that we're having newer drugs that are working better. So these are some of the examples of the anticonvulsants that we have in the market. So what's important to note is that you need to know the indication. What kind of seizure is this patient having? Are they having a generalized seizure? Are they having a focal seizure? Because we said that some anticonvulsants can actually make the seizure worse. You need to know the side effect profile of the drugs that you're giving to your patient. For example, if you're giving your patient phenytoin and fosphenytoin, we know that it should not be used for absence or myoclonic seizures. Phenytoin should be given very slowly when it's given IV, because if given rapidly, it can actually cause bradycardia and death. We've had patients die because the phenytoin was pushed in too quickly. Sodium valproate is a good drug. It has broad spectrum. It's a good choice for many of our patients coming with convulsions. However, you need to monitor your LFTs, because these patients can actually end up getting very bad liver disease from the valproate. It's also a concerning drug for preteens because it's been associated with teratogenicity. Carbamazepine is a very good drug for focal seizures, although it can also be used for generalized seizures. Carbamazepine can actually make absence and myoclonic seizures worse. So it is not the best choice of drug if you're having this type of seizures. We have other newer drugs. We said levetiracetam is a second-generation anticonvulsant, and it's used for many types of seizures, myoclonic, focal, generalized tonic-clonic. Vigabatrin, we also mentioned, is a very good drug for patients who have West syndrome or infantile spasms. However, you have to constantly do your ophthalmological examination because it can long-term, it can cause actually visual impairment. But you see, this is risk versus benefit because patients with infantile spasms tend to be quite refractory to our traditional anticonvulsant drugs. Then we have other new drugs coming about, such as Clobazon, Clobazon, which falls in the same class as our benzodiazepine. It's a broad spectrum anticonvulsant, and it's quite effective for many types of convulsions. So this is just to make you aware that we have very many anticonvulsants in the market. Now, cannabinoids are something that is becoming more and more popular in Western countries, and there have been many case reports of the use of cannabinoids in treatment of severe drug-resistant epilepsy. And of course, we have ketamine for resistant status epilepticus. So aside from our anti-epileptic medication, it's good for you to be aware that there are other ways of treating epilepsy, especially for patients with refractory seizures. We have surgical procedures. For example, if you find a patient has cortical dysplasia, you can actually take out that part of the brain, or temporal lobectomy for the patients who have temporal lobe epilepsy. Other surgical interventions would be based on how severe the patient is. For example, we have what we call corpus callosotomy, in which you separate the right and left hemisphere for these patients who have severe epilepsy. Unfortunately, many of these epileptic surgeries are not done locally because they require extensive workup. We have other things like vagus nerve stimulation, deep brain stimulation, laser interstitial thermal therapy that have also been shown to be quite effective for treatment of epilepsy. I have not mentioned here, but we have also the ketogenic diet, which has been shown to work very well for refractory seizures. It usually consists of high fat, low carb, and moderate protein diet. So what are some of the management challenges for treating epilepsy in our setting? We have few pediatric neurologists in our setting. Again, recognizing epilepsy syndrome can be quite challenging. Dravet syndrome, we said, is usually for a patient with recurrent febrile seizures. You may actually just keep treating this patient as a febrile seizure, but they actually have Dravet syndrome. Lennox-Gastaut syndrome, these patients have all types of seizures. They have absent seizures, myoclonic, tonic, clonic. So sometimes for us clinicians, especially when we are not trained in epilepsy, we may actually not be able to recognize these syndromes and end up giving the wrong drug to our patients. Syndromic diagnosis has implications. Again, recognizing underlying CNS infection requiring acute intervention in epileptic patients is important. So you don't just start your patient on anti-epileptic medication, but you need to recognize, why is my patient convulsing? Again, I'll give the example of the patient who we currently have in one of our pediatric wards, who had been to several hospitals, and they ended up in PICU, had been treated for meningoencephalitis for almost 21 days, and we were trying to figure out, why is this patient still convulsing? Fortunately, we had a pediatric neurologist who came, consulted with us, and we were able to do our autoimmune panel. And that's how we ended up discovering that this patient had NMDA receptor encephalitis, which has a very specific treatment. We have other things like ADEM, acute demyelinating encephalitis. So don't just routinely think every patient who comes with a fever and convulsing has meningitis. You actually have to investigate for other causes. We know meningitis is not just bacterial. This patient may be having a viral meningitis, or even a TB meningitis or a fungal meningitis. So always think about the underlying CNS infection that is triggering this patient to have multiple seizures. So recognition of complications of epilepsy is also very important. We have what we call mesial temporal sclerosis, which is a complication of patients who have recurrent seizures. Again, they'll have intellectual disturbances, among other long-term complications. Then we have implications of prognosis, therapy, and genetic counseling. we say, as I've mentioned, therapy usually for epilepsy. Once you make a diagnosis of epilepsy, you're basically committing these patients to be on anti-epileptic drugs for a long time. So you really must discuss with the patient all the implications so that you choose the best drug, least side effect profile, and the patient also understands why they're on the medication. And also you need to discuss about the prognosis. Some epileptic syndromes have a poor prognosis. They're quite difficult to treat. The patient may have refractory seizures. So you must discuss all this with your patient. Again, we have lack of advanced therapeutic solutions similar to Western countries, such as deep brain stimulation, vagus nerve stimulation, and surgical resection. We have things like ketogenic diets that can be done locally, but you can imagine how difficult it is, even for the Kenyan, you're telling your mother that this child should not eat any carbohydrates. Hawezi kula ugali, hawezi kula mchele, akule nyama peke yake, it's na vegetables. It would be quite difficult to implement this unless we have people who are trained specifically in the ketogenic diet and can support our patients. So I'll discuss a little bit about status epilepticus because it's something that we commonly see. Status epilepticus is a condition resulting from either the failure of from the failure of mechanisms responsible for seizure termination or from the initiation or from the initiation of mechanisms which leads to abnormally prolonged seizures after a time point 1. It's a condition which can have long-term consequences after a time point 2, including neuronal death, neuronal injury, alteration of neuronal networks, depending on the type and the duration. So what does this mean? I know traditionally we've thought of status epilepticus as a patient convulsing for more than 30 minutes, but the International League Against Epilepsy has actually changed this definition. So if you have a patient with a tonic-clonic seizure who's having a seizure for more than 5 minutes, then they're in status epilepticus. And if this patient continues convulsing for up to 30 minutes, then they're at risk of long-term consequences such as neuronal injury. If you have a patient with absent status epilepticus, meaning they're having absent seizures for more than 10 to 15 minutes, that is status epilepticus. And we don't know how long this can go on to cause neuronal injury. If you have a patient with a focal seizure, focal status epilepticus with impaired awareness going on for more than 10 minutes, the patient is in status epilepticus. And if this goes on for more than 1 hour, then we are at risk of long-term consequences. So it is very important to intervene early for patients with status epilepticus. So this is from the basic pediatric protocol, which are our Kenyan local guidelines for managing a patient with a prolonged seizure. So, and it's mainly for a patient who's more than 1 month. So if the convulsion is going on for more than 5 minutes, you need to do your ABCs, check your airway, your breathing, your circulation, start this patient on oxygen. You should have taken a sample, check for hypoglycemia. If hypoglycemia is present, you need to bolus this patient with 5 ml per kg of 10% dextrose. If you have a line in situ, you quickly give diazepam at 0.3 milligrams per kg, slowly over 1 minute. If you don't have your line, you can actually give your rectal diazepam at that dose. And remember, you have to keep checking your ABCs. If the convulsion continues for beyond 10 minutes, then you need to give a second dose of diazepam. In other settings, they use drugs such as lorazepam. So it's good to know other drugs that you may use. Continue with oxygen. Check and ensure that your airway is clear always. If your seizure continues for more than 15 minutes, you need to load this patient with phenobarbital. Remember that you should not give more than 2 doses of diazepam once phenobarbital is used. And once you do this, you give a maintenance therapy of phenobarbital at 2.5 milligrams per kg. Continue with oxygen and check your ABCs. If the convulsion persists beyond this, then you need to call in your anesthesia team so that we can do total sedation of this patient with drugs such as a midazolam infusion. And always remember to keep checking your ABCs. Now, remember, for a patient with epilepsy, a lot of them may have been on phenobarbital, or they may have been on phenytoin, which we also use in our setting for treatment of status epilepticus. So sometimes you may have to use other drugs. There are many new drugs coming in the market, such as levetiracetam, and sodium valproate, which can actually be used for your patient with status epilepticus. Now, I'll talk a little bit about pre-hospital guidance for patients who have, what do you tell your patients? So basically, you need to tell your patient to stay calm. You need to check your time. You need to stay with the person until the seizure stops. Move or guide away from harmful objects. Remove glass, loosen the clothing. Stop crowds from coming. We know as Kenyans, we like to run and look when you see something is out of the ordinary. Turn the person on their side if they are not awake or aware, and call for help urgently, especially in patient who's having status epilepticus, is unconscious, is having difficulty in breathing, if you're having a seizure in water, if there's injury, or if this patient is known to be sick. For patients who have epilepsy, commonly you'll find that they actually have some sort of rescue medication with them, such as diazepam. If you're able to then administer this rescue medication. For the safety at home, a patient who's known to have epilepsy, you should have a little furniture. Don't have so much clutter in your house. Protect sharp edges and corners. Use round cornered furniture. For glasses, use strong ones in case the patient falls on them, and use a safety film. Beds should be low level with a firm mattress. Try and put carpets, wooden floors, they are safer. Protect stairs with carpets, and consider having safe gates, especially if you have a pediatric epileptic patient. Cooking, preferably if your epileptic wants to warm some food, advise them on use of microwaves rather than open flames, and you turn the handle to the side. Bathing, use of showers with flat floors. If using a bath, you should always start with the cold water, then you add the hot water in case the patient convulses on their own. Do not overfill the bathtub. Do not use plugs in case the patient convulses. Make sure that the family members are aware that you're having your bath. Avoid locking the bathroom door. Use engage sign instead. Doors should ideally be opened from the outside or both ways. A seizure diary is very useful for patients who are known to have epilepsy, where they record the frequency, the duration, the medications used, and possible triggers of the seizure. Protective helmets are good for atonic seizures because we said they commonly have multiple injuries. These patients, especially the teenagers, should not smoke in bed, should have smoke and fire alarms in case you have an injury, perhaps when the patient is cooking. Seizure alarms are also useful, and medications should be kept safe, and the caregiver should be taught how to administer correctly and promptly. And remember, sometimes a caregiver can actually be the matron in school if this patient is in a boarding school. For schooling, you need to inform the school about the seizures, prepare a care plan for management of seizures, and share it with the school. Try and avoid midday medications. It's best to give anticonvulsants that are given morning when the patient is leaving for school and evening when they come back home. Involve the school nurse, educate and train for rescue medication, ensure continuity of education, and minimize absenteeism. Actually, if you come to the KNH Pediatric Neurology Clinic, you'll find that almost 70% of these patients do not go to school. Why? Because you find that the parents feel that this patient should be completely seizure-free before they attend school. And you know, sometimes this can be quite difficult to achieve. You should consider strict triggers in school, such as stress, missed meals, dehydration, and fatigue. Use of computers and interactive boards should also be looked into. We know that flashing lights can trigger seizures. For the lab and sports, consider potential hazards, especially when these patients are in the lab, such as chemicals, swimming. We know hyperventilation can trigger absent seizures. So these are things that we must bear in mind when your epileptic patient is attending school. So a little bit about epilepsy and photosensitivity. Actually, in 1997 in Japan, there was a cartoon called Pokemon cartoon. It actually caused seizures. 700 children developed seizures on watching the cartoon. And this was because part of the display showed an alternate red pattern. You can actually Google this and see. So sometimes bright lights can trigger seizures. About 5 to 12% of people with epilepsy are photosensitive, triggered by flashes, flickering, and by certain patterns. It's more common in girls than boys. It can occur both due to natural or artificial light. So natural, actually the sunlight reflection from water, sunlight reflecting through leaves, or there's something called sunflower syndrome, where if a patient faces bright lights and they put their hand on their face, it can actually trigger a seizure. Artificial TVs, videos, computer games, we know that our teenagers love these. Flashing games, fireworks, and even discos can trigger seizures. Patterns such as geometrical shapes, road markings, and strips. So it's a common presentation for self-induced seizures, and diagnosis of this photosensitivity is usually by EEG when you do photic stimulation, that is stimulation with light. Now, we cannot talk about epilepsy without talking about sudden unexpected death in epilepsy, or SUDEP. So it's a sudden unexpected death of someone with epilepsy who was otherwise healthy. In SUDEP cases, no other cause of death is found when an autopsy is done. And each year we have actually more than 1 in 1,000 people with epilepsy die from SUDEP. They just die and you do not know what the cause is. And it's a leading cause of death in people with uncontrolled seizures. The best solution so far for sudden and unexpected death in epilepsy is proper seizure control. So I'll end my presentation there. I'll now invite Dr. Anne Kamunya and Sister Kagema to bring in some comments, and we will take questions. Thank you.
Thank you, Lucia, for that comprehensive presentation. And I'm Dr. Anne Kamunya. I'm a pediatric neurologist at the EB Level 5 Hospital. So that was a very good presentation. And just a few comments about epilepsy in children, which I would like us to take as take-home message is first to note the new classification of epilepsy according to the International League Against Epilepsy, the 2017. This is because we have the older terminologies we used to use for seizures has now been done away with. So we no longer use the terms we used to use as the glad mal epilepsy to mean for the generalized seizures, or the petit mal seizures for absent seizures, or the complex partial or simple partial seizures. We have now, we all talk of either focal seizures, focal onset seizures, or generalized onset seizures, or unknown onset seizures. And why is it this important? So that we are all able to, everyone taking care of a child with epilepsy, we are all able to talk in a common language so that we can easily recognize the seizures and institute a proper management. And then when it comes to treatment of these children, it's good to recognize that the drugs we use will depend on your type of epilepsy, this possible epilepsy syndrome, which is diagnosed, and some of the drugs may be contraindicated in some age groups. Like in the neonates, we try to avoid the sodium valproate for young children aged less than 1 year, especially if you have not done your metabolic workup, because sodium valproate can cause a metabolic compensation. And then we also need to consider side effects of most of those drugs so that we are able to recognize early and maybe change the patient to safer drugs. For example, drugs like sodium valproate. It's a commonly used drug, mainly because it's a broad spectrum. It's easily available and widely available, and it's cheap. So, but it has also quite significant side effects. Remember, you can get hyperammonemia, liver derangements, and it can cause pancreatitis and other major side effects. So it's good to recognize side effects of some of these drugs so that you are able to recognize them early. And Otherwise, when it comes to diagnosis of a patient with epilepsy, how to approach a patient with possible epilepsy. First, history is very important and clinical examination. In your history, when a patient comes with possible seizures, it's good to know that children also will present with movements which are non-epileptic. So it's good to be able to recognize, to be able to rule out non-epileptic seizures and be able to recognize epileptic seizures. And also, it's also good to know that the EEG, which is a common test, which is most people will ask for as a diagnostic test for epilepsy. It's actually not, it's only aids in diagnosing of epilepsy. It's actually not a diagnostic tool, because most of the time, by the time you do an EEG, the child may not be having a seizure. So you'll get we'll be doing what we call an inter-ictal EEG, which may be normal. And actually, patients, EEG will only yield about only 50% of patients with epilepsy will have an abnormal EEG. So it's good for us to recognize that when you're asking for an EEG, it should only be able to aid in the diagnosis of epilepsy, but a normal EEG does not rule out epilepsy. Then the other important thing is the imaging. The choice of imaging we have in our setup is either have the CT scan or the MRI brain. The CT scan is important for a patient who comes with acute seizures and you want to rule out a possible structural cause, which you may need emergency management. Let's say a patient had traumatic head injury, and maybe there's a bleed, or the patient has a subarachnoid hemorrhage, which may need neurosurgical intervention. So a CT scan is usually done mainly in the emergency situations, like when the patient presents acutely in the emergency department. But the MRI of the brain is actually the imaging of choice for patients with epilepsy. Now we usually do MRI with an epilepsy protocol, because MRI is able to diagnose most of those structural causes of epilepsy. Otherwise, that's the comments I have for now. Let's give Sister Kagema a chance to make her comments before we answer the questions.
Good afternoon. Can you hear me? Thank you, Dr. Rushia, for having given us the view of epilepsy, the type of seizures. Thank you, Dr. Ann Kamunya. Epilepsy is a condition that is really challenging for all of us. And in this sense, we needed to talk about the issues that happens after getting seizures, like the issues of behavior in our adolescents, the youth, the teenagers, even in our children after a long treatment of seizures. The other thing is about creating awareness, asthma education to both health workers, both caregivers, together with the school, and also enhancing good policy for both institutions, Minister of Education, Minister of Health, Judiciary, and even Police Department, because as Dr. Lucia Amoro had said about, it brings issues later in life, because you have to live on long treatment. Some of them develop psychiatric issues, yet it's because of seizures, or because they are either preempting the seizures or before or post. And some of those things has made our people to be incarcerated in the cells just because somebody did not understand, or issues of drugs, medicine. We should have a policy where the medication for epilepsy is affordable for everyone who having seizures. That can be affordable for every person from the county level to the tertiary level. And the other thing is that always monitoring our children on the seizures, always knowing, being aware, even when the child is sleeping. It's good to just check whether you have gotten a seizure at night, because you may get a seizure. Because many of the parents have found their children dead in bed because of SUDEP. It's good just to keep on checking when a child is asleep. You keep on checking what is really happening. I didn't know how much time we needed to talk, because I had a small short presentation on issues on the abnormal behavior in the epilepsies, which I don't know whether I was supposed to bring it up or not.
I think you can proceed with it.
Okay, thank you. Let me bring it. Can you see my presentation? Yes. Can you see my presentation?
Yes, we can.
Okay, thank you. And it's about epilepsy vis-a-vis behavior change. And above all, as a mother, as a health worker, I'd like to dedicate this presentation to all the persons living with epilepsy and parents with children with special needs and epilepsy. We are in the month of December. I would like just to highlight the 3 important days for the epilepsy. The International Epilepsy Day is in February every year. Awareness is in November last month, where we should have done treating of awareness. And then epilepsy also falls on issues of disability. It's always done in every December, that December every year. So I want to acknowledge my family. I want to acknowledge Professor Mayo, Dr. Kigamu, and the entire KNH fraternity for the support. You're all welcome. I want to talk about the objectives. Is to distinguish behavior change that occurs on or before and after seizure or conversion in a person with epilepsy or an epileptic client, to educate clients, caregivers, and families on change that may occur before or during conversion and the effects of behavior, to distinguish the pre-ictal and post-ictal behavior in patients or clients who have mental disorder due to epilepsy, to analyze threats and issues of behavior change in epilepsy. That is the brain, the lobes of the brain and the executive functions that happen in the brain that help us to understand what really happens when you're having issues that are like in the frontal lobe. It's where we solve the problem solving and the emotions and behavior control and personality is done. You have the motor cortex where there's movement. There's the vision, there's the parietal lobe, which has a perception, making sense of the world. We have the temporal lobe, which is of memory, understanding, and language. So I come back to the definition of the epilepsy. Earlier on, it was said by Dr. Lucia. It's a central nervous system disorder in which brain activity becomes abnormal, causing seizures or periods of unusual behavior, sensation, and sometimes loss of awareness. I want to say that anyone can develop epilepsy, not only in children. You can also develop epilepsy even when you are an adult, either due to other causes like accident, head injury, or other issues that may cause epilepsy. So anyone can have, and epilepsy both affects males and females of all ages, ethnic backgrounds and ages. When I talk about epilepsy and behavior disorder, there are few epidemiological studies of incidences and prevalence of intellectual behavior change in patients with epilepsy. In addition, 20 to 30% of patients with epilepsy demonstrate some abnormal behavior, sometimes mainly anxiety and depression. Episode of psychosis in life may range from 4 to 10% and increase to 20% in patients with temporal lobe epilepsy. The prevalence of behavior problems in children with epilepsy is approximately 12 to 95% and exhibits some form of behavior change. In controlled studies, children with epilepsy are found to have significant greater occurrence of behavior change than those without. The estimate vary according to the population studied, and a lot of studies suggest that children with epilepsy are at risk of developmental behavior disorder. We talk of classification of patients with epilepsy. There is seizure related. This include periictal, parental associated with increase in seizures and clusters, forced normalization. The second one is interictal related. Those are some of the behaviors that affect when person has had epilepsy. There's a schizophrenia like psychosis, paranoid state, affective disorder, and personality disorder. The third one is interictal personality syndromes. These are characterized by the following features: depression, hyperreligiosity, disorder of sexual dysfunction, irritation, and viscosity. So there is episodic dyscontrol syndrome. This refers to sudden episode of spontaneous release violence, often with minimal provocation, that are brief and terminate abruptly, may be precipitated by some small amount of alcohol. This may be evidence of subtle cerebral damage. The syndrome may be associated with epilepsy. When you talk of IDD or interictal dysphoric disorder, it refers to patients with epilepsy who have dysphoric symptoms like irritability, depressed mood, insomnia, typical pains, anxiety, euphoria, and these symptoms are more often short-lived, but they're intense and recurrent. We have the forced normalization. This refers to patients who develop behavior change when seizures come under control. It's a phenomenon usually of acute onset. It's forced normalization behavior changes symptoms. Forced normalization behavior changes symptoms are as follows. There's depression, anxiety, conversions disorders, psychosis, agitation. The behavior could be acute onset in some of the patients, eventually interictal psychosis, which emerges over time as seizures decline. It can be precipitated by AEDs or anti-epileptic drugs, like the vigabatrin, barbiturates, benzodiazepines, and azoxystrobin. When you have post-ictal psychosis, it arises after a cluster of seizures that emerge following a lucid interval of up to 3 days. Onset is abrupt with the following: violent behavior and suicidal ideations. Post-ictal psychosis may last several days or occasionally weeks. The factors that are affecting behavior in epilepsy: there may be behavior change. The relationship between behavior disorder and seizure type is clear. The increase of behavior disorder been found to be associated with 1, focal seizure, temporal lobe epilepsy, generalized seizures. Studies suggest that number of different seizures may be an important factor, e.g. like temporal lobe epilepsy and generalized seizures has an increase on behavior disorder. This is a brain, and it shows most of the parts of where the behavior comes, like the cognitive, the creative, the judgment, the personal components, memories, and problem solving. So sometimes where this, it matters where the seizure has started. The factors of affecting behavior: 1 is age of onset. Behavior disturbance increases as age increases, although not much study being done. As the child grows down, as the children grow, as they continue becoming teenagers, as they continue becoming the adolescents, behavior suddenly changes because of the where the brain has been affected or where the seizure has been affecting. There is also frequency of seizures. The more of the seizures, the more you get seizures, the more there is brain damage. That's behavior disturbance. There is behavior and cognitive function, There's link between poor cognitive function and behavior disturbance. IQ is most associated with behavior disorder and vice versa. There is also sex, no much difference between boys and girls. Boys with epilepsy are more affected with behavior disturbance than girls with epilepsy. Aggression and antisocial behavior disorder is often associated with boys, while girls have got neurotic behavior disturbance. Medication is also a factor that affects. Some of the ADs have been associated with behavior change, e.g. like phenobarb, barbiturates, epanutin. The other factors is about family and environment influence. A disturbed home and a family discord, maladaptive or negative family and parental attitudes, over anxious parents, inappropriate child management, parental disturbances where there is unstable and divorce, discrimination and stigma, where either in family, society, school, and workplaces. The psychosocial and cognitive and behavior change in people with epilepsy. One is about driving. Most of them, they are not allowed to drive because they can get seizure anytime that they are driving. They may not know. Sometimes there is embarrassment. You're always embarrassed because of your condition, because you never know where you get a seizure, where you get a conversion. Sometimes it causes embarrassment because sometimes they pee on themselves. Sometimes there is a lot of things that happen around them. There's the physical limitations, there's social support, social activities, employment. If you know that you have epilepsy, no employment you can get, the employers will not give you. There's a lot of stigma of epilepsy, discrimination. It's real and it's perceived. There's lack of self-esteem and the dependence because you all keep on depending on other people in case you get a seizure. There's a speed of mental memory. Sometimes they have a loss of memory after a seizure and many other things that happen during that. The cognitive is about memory, language, and judgment reasoning. We talk of behavior, emotional well-being, emotional limitation, anxiety, paranoid and psychosis, fear concerning seizure, effects of medication. In conclusion, I want to say this: behavior disturbances can be associated with seizure variables, e.g. the type of a seizure and frequency, age of onset, duration of seizures, presence of brain damage, may be exacerbated by AEDs medication. Family and environment factors are also contributing factors. Etiology, factors related to epilepsy itself, e.g. abnormality, gender, and medication may have a role to play in genesis of behavior disorder. The way forward: training of more specialists, both doctors, clinical officers, and nurses on epilepsy. There is urgent need of epilepsy nurses, neurologists, and epileptologists. Promote compliance and adherence, education, stigma reduction, community awareness, good government policies in collaboration with all stakeholders, e.g. Ministry of Labor, Ministry of Health, Ministry of Education, National Council of Persons with Disability or living with disability, Judicial and Police Department. Enhance good policies that will protect people with epilepsy and disability. Disability mainstreaming in organizations, in government institutions, training for the caregivers on what to do in case of a seizure, basically on home first aid, counseling of clients and caregivers, good maternal and care, pre and intra and postnatally, rehabilitation centers and vocational training, especially for those who have developed, who have the neurodevelopmental issues that they have not been able to acquire the formal education. They can always get to rehabilitation centers where they can learn on how to do things in their own hands, ensuring availability of drugs to all by making them affordable. And we need to come back and do school health programs, which is very important to our students to our children. As Dr. Lucia had said, that most of the children don't go to school. We need to go back to the basic. We start doing school campaigns and enhance education and even empowering them and ensuring that our children also go to school. Even if they'll not make it in a formal education, you always learn a skill that will maintain them, will take care for them later in their years. Not epilepsy is a CNS disorder and can cause disability if not well managed, affecting the cognitive and behavior centers. Those are my references. And thank you to the ed.
Thank you, Joanne, for that excellent presentation that you have made. So we can see that epilepsy is something that's quite relevant in our setting. We'll now move on to take the questions. So Dr. Kamunya, myself, and Joanne will just answer the questions that we are seeing in the Q&A. There's one question that has been asked: when infants are very febrile, at times they convulse, is it still epilepsy or febrile convulsion? And if not, when shall the diagnosis change to epilepsy if they are still febrile? Any child who comes with a convulsion and fever must be investigated, especially for a first-time convulsion. So you must do the entire panel, including doing a septic screen, include your lumbar puncture because you must rule out meningitis. You have to do your electrolytes, you do your full blood count, your CRP, basically trying to find the etiology. So febrile convulsion is actually a diagnosis of exclusion. So only after you've excluded all causes, including meningitis, is when you can now label a patient as having a febrile seizure. But remember, febrile convulsions usually begin at 6 months to 6 years. So a child falling outside this bracket should not be labeled as having a febrile convulsion.
Thank you, Lucia. I can take this another question. Is diazepam being phased out as first line for emergency treatment of seizures in children? Currently, midazolam is what is available in the public hospitals. How can we administer midazolam since it is indicated for IV, IM, or IV or IM use? Can the IV or IM type be administered per rectal or buccally in emergency situation for children in our setup, since we do not have intranasal ones and that are available in an advanced setting? So for emergency care of children who come with epilepsy, for the first line medication is the benzodiazepines. And the choice of benzodiazepines we have, it's either the diazepam, which can be given either per rectal or intravenously. We also have the lorazepam, or it goes most of the time, it goes by the trade name of Ativan. And this is also given intravenously. And also we have the midazolam. Midazolam is also an indication, and usually it can be given buccally. Midazolam and diazepam, either given per rectal or intravenously, and lorazepam have been shown to have equal efficacy. So whatever you have, you can actually use any of those medications. The problem with giving midazolam IM is the erratic absorption of midazolam. So ideally, use if the midazolam is what you have, give it midazolam, and if you have an IV access, you can also give it as an IV intravenous.
Thank you, Anne. I'll take another question. Some children with epilepsy present with neurological disability. I am concerned with children with swallowing difficulties. What could we do in this circumstance, and any drugs that are used? That is true. Often patients with epilepsy will have associated comorbidities. For example, we often find patients with cerebral palsy having difficulties in swallowing. So any patient with swallowing difficulty should be assessed actually by the gastrointestinal specialist, the occupational therapist, so that we can do swallowing assessment tests, such as the upper GI study, so that we can see how severe this issue is. And once we make a diagnosis on what the issue is and how severe it is, then we can look for the way forward in terms of treatment. Because we know a patient with epilepsy still needs adequate nutrition. So usually you need to do an adequate assessment by doing the upper GI study, and then we decide the way forward from there. There are treatments available for that.
Then there was another question. What do you do when an anticonvulsant, when a patient on anticonvulsants has delayed liver function tests? So when a patient has delayed liver function tests, you need to consider the most probable anti-seizure medication, which can cause delayed liver functions, like, for example, phenytoin, the and epilim, and carbamazepine. So if a patient is having increased enzymes, especially the ALT and AST, you have another, you can choose to, there are alternative drugs which are safe, such as the topiramate and the levetiracetam. So you can always change your patients from those anticonvulsants for alternative anticonvulsants.
Thank you, Anne. There is another question. What would be your target seizure-free period before tapering off medications? For a patient with CP and epilepsy, are we ever able to wean off meds now that there's an underlying brain damage? Those are excellent questions. So usually if you're 2 years seizure-free, then we usually attempt to taper off the medications. Remember, we don't stop the medication immediately, but we slowly taper off. Various neurologists use various principles in the tapering off. Some would use fast in, fast out. Others use fast in, last out. And then some of them would usually have the dose. Like, for example, if you're on phenobarbital, 90, you go to 45. So you slowly taper off. If at any point you find that the seizures recur, then you have to go back to the last dose when the patient had good seizure control. Again, when you're tapering off the medication, to do or not to do an EEG, it's always good to do an EEG just to make sure that the seizures are well controlled. But remember, EEGs would only be positive if they are done during the convulsion. We can have the interictal period where if a patient was well controlled, you'll not really see anything on the EEG. So you cannot always rely on the EEG when you're tapering off medications. Now, for children who have underlying CNS disease, for example, cortical dysplasia, microgyri, a tumor, or even cerebral palsy due to hypoxic ischemic encephalopathy, that's birth asphyxia, or post-meningitic sequelae, because they have underlying brain damage, then they are predisposed to having convulsions. So many of these patients would usually still need to be on an anticonvulsant, but the lowest dose possible to avoid minimum side effects. And this is especially so for those who have some sort of structural brain lesion.
Then take another question. Can a serum amylase of 98 with an upper normal of 100 be contraindicated in epilim chrono? What I'll say about epilim, if the patient has these high serum amylase levels, first consider the clinical status of the patient. Is the patient having any features of toxicity due to epilim? And then if you are able to do an epilim level, it's good to do an epilim level, because if they are in the toxic range, you may have to either stop or even reduce the dose of the epilim. So, and also, so a level with no symptomatic manifestation of toxicity and without an epilim level, it might be hard to just stop the medication. So it's good to monitor.
Thank you, Anne. There is another question. I'll answer two of them together. Is there a possibility of remission in epilepsy, and can epilepsy be cured? So usually the International League Against Epilepsy previously defined epilepsy remission when you're 5 years seizure-free, but now they've expanded it to definition of remission as 10 years seizure-free, with the last 5 years being off anti-epileptic drugs. So usually we don't say epilepsy is cured, but we can say that you are in remission when you have been 10 years seizure-free, with the last 5 years being off medication.
There's another question here. A patient walking and loses consciousness, but regains consciousness after walking for a long distance, followed by severe headache. Which kind of epilepsy is this? What I would say this patient may need further assessment to rule out the possible causes of epilepsy, and also rule out other possible other causes like a cardiac disease or any structural. So further workup for this patient is needed before really diagnosing as epilepsy. You need to do an EEG, you need to do imaging, you need to do an echo or an ECG to rule out other possible causes of similar presentation.
Thank you, Anne. There is another question. EEGs can be triggered in various ways in case of need to confirm diagnosis of EEG, sleep deprivation, photic stimulation, however cautious. Yes, true. When you're doing an EEG, there are certain things you can do, what we call activation procedures, in order to try and get a positive indication from your EEG. Because as I mentioned, sometimes you may be doing the EEG when this patient is not in the ictal period, basically in the interictal period. So for example, for patients who have absent seizures, if you trigger this patient by telling them to hyperventilate, for example, to try and blow on a paper continuously to hold it straight, as they hyperventilate, it can actually trigger a seizure. As I mentioned in my presentation, there are also some patients who photic stimulation can trigger seizures. Also, sleep deprivation, as has been mentioned by this person. Usually, before you do an EEG, sometimes if you just like keep your child awake overnight, or let them go to bed very late, wake up very early before they do the EEG, that can actually enhance the likelihood of the EEG picking up something unusual. However, as we said, EEGs can sometimes be normal in a patient who has epilepsy. So you need to treat the patient and not the EEG. That said, sometimes you can also have electrical, you can have, like, for example, a patient can be having a seizure that is only detected by the EEG. So that we tend to pick that more, for example, in the neonates who are on continuous EEG monitoring, like if they use the amplitude integrated EEG in the NICU setting, maybe this is a patient who has asphyxia or whatever else, and they're on continuous monitoring. So you'd be able to see if you're having an electrical seizure without a corresponding clinical seizures. So yes, EEGs are quite useful in the management of patients with epilepsy.
Then there's another question. Thank you for the excellent presentation. Can we develop a seizure protocol or guideline, especially in acutely ill child? Actually, I said that there are protocols which are available and the guidelines for management of acutely ill child who comes in seizures. Most of these children will present in status epilepticus. So yes, protocols are available. Maybe we just need to adopt them and in our various clinical settings, and then we can make use of them. Then there's another question, Dr. Amolo, maybe it's for you. Where can we refer patients in KNH?
So you can refer them to the pediatric neurology clinic, which we run every Tuesday from 8 in the morning up until lunchtime. You usually need to come with a referral note so that you can be able to be admitted into the pediatric neurology clinic. However, something that's very important to note is now we're moving towards down referral, because a lot of patients are in the counties, so they all can't come to KNH. We have excellent pediatric neurologists like Dr. Anne Kamunya is in Embu level 5. So these patients who are coming from like that jurisdiction do not need to come all the way to KNH. They can actually be seen in a place that is closer to them and more convenient to them. Thank you.
Then there's another question. Kindly comment on the use of valproate in babies below 2 years of age that the liver is not mature enough. Actually, the main contraindication for use of valproate in children below 2 years of age is mainly if the patient has a possible metabolic, a neurometabolic condition, because valproate will precipitate a metabolic crisis. But if you have ruled out a metabolic condition in these children, valproate is not actually completely contraindicated, because valproate is one of the most useful drugs we have, because it's broad spectrum and I had said it's cheap and available. So we use it in most of our children, but we should, if we can be able to rule out metabolic conditions in these children, then valproate will be safe.
Thank you, Anne. There's another question on what precautions to take on children with comorbidities such as TB and HIV. I think what you need to worry about most is drug-to-drug interactions. For example, if you have a patient who's on sodium valproate and is on rifampicin, we know that this can cause rifampicin can induce liver enzymes, and we've said that sodium valproate can also cause liver toxicity. So it's basically just looking at your drugs and knowing what drug-to-drug interactions that could possibly occur that may cause increased drug levels or even increased clearance of the particular drug. So it's just sitting down with whichever clinician is seeing you and looking at the drugs and just trying to come up with the best concoction to give your patient.
Maybe Dr. Lucia, you can answer this. Is a twitch a seizure?
A twitch, yes, a twitch can be defined as a seizure. So twitch is a very layman term to use. So you basically have to use your clinical acumen. For example, we said we have patients who have automatism. For example, you may have a patient who has lip smacking or chewing movement, and that may actually be a seizure. Or sometimes you may find a patient is having a focal seizure where just on the face, like on the facial muscles. So basically being able to pick this easily, and this comes from seeing many cases and knowing what exactly that you should be looking for, because a lot of times focal seizures will just be on one side of the body. So you have to be very keen to be able to detect that.
Then there's a question, how do you deal with hyperactivity in a child with epilepsy, currently on valproate and phenobab? Remember, a child with epilepsy may be having a comorbid ADHD, so they present with hyperactivity. But also, phenobab is also a possible cause of one of the side effects of phenobab can be hyperactivity. So it's good to try and differentiate whether this patient is having a comorbidity or is it a side effect of the phenobab. For me, what I would do is, if this child is well controlled on valproate, I would try and withdraw phenobab and see whether the hyperactivity resolves. If it doesn't resolve, then you need to consider whether this patient is having a comorbid ADHD.
Thank you, Anne. There's a clarification, a comment on focal aware or focal unaware. So basically we said when you have a focal seizure, you need to check for awareness or impaired awareness. So awareness is basically if the patient is aware of self and surroundings, and awareness is if you try and elicit a response for this patient, they will not be able to elicit a response. So for example, if a patient is having a tonic focal seizure, you may see one hand is moving, but when you talk to the patient is able to respond, and but a focal unaware seizure, on the contrary, you see maybe one hand is moving and you try and elicit a response from the patient, but the patient does not respond when you try and engage them. You can get more information on the classification of seizures with even videos on either the International League Against Epilepsy, and even YouTube has a lot of videos where you can see the different types of seizures. Maybe Anne, you can take this. Somebody is asking, when do you suspect a metabolic etiology, and are we able to screen for metabolic disorders locally?
Yeah, for metabolic etiology, most of the time, it usually manifests early in life, especially in the neonates. So you get a neonate who suddenly decompensates, and it's very much possible to miss a metabolic disorder in a patient because most of the neonates are treated as having neonatal sepsis. But if you have looked for possible source of sepsis, you have done your septic screen and none-revealing, always to think of a metabolic disorder in these children, because these children present with seizures, they will be encephalopathic, and they will be very sick children. Or it can also present later, depending on the severity of maybe the metabolic defect. So a patient with an underlying metabolic defect maybe have an acute infection like an acute gastroenteritis or acute febrile illness and suddenly decompensates. So to rule out a metabolic disorder, what we do is the basic metabolic workup you can do is to do an ammonia, a serum ammonia and serum lactate. And ideally, don't use a tourniquet when you're taking these samples. Take a free running sample, and it should ideally reach the lab within a very short time, preferably within 30 minutes, and you put your samples in ice so that you get a good results, because if that sample is not well taken, you get high levels of lactate and ammonia, and you might wrongly diagnose your patient as having a metabolic disorder. Then there are other specific presentations of patients with metabolic disorder. Maybe a patient comes with an acute compensation and later develops a movement disorder. So you're thinking, is this patient having a possible organic acid failure? Then you can go on and work up your patient if you suspect such.
Thank you, Anne. I think we have been able to answer all the questions. We will email the presentation through the KNH Research Committee so that we can reach all of those who have requested for the presentation. And we hope this presentation will help you, just guide you as you refer patients to whichever pediatric neurology clinic that you do. Thank you. Enjoy your day.
Thank you very much. Thank you very much, Dr. Lucia Molo. Thank you, Dr. Anne Kamunya, and thank you also, Sister Joan Kagema. That has been a very elaborate presentation on matters to do with seizures and epilepsy, and we really appreciate. We've learned a lot. I've personally learned a lot. We thank our participants for staying with us till now. We are now closing up. We'll be having several sessions throughout the week in the afternoons. Please join us for more learning sessions in the afternoons. For the presentations, as has been mentioned, we'll have them uploaded at the KNH website, and you'll be able to get them. For the specific session that you'd like, you can email knhresearch@gmail.com, and you'll see how best, and we will be able to give you the code and you download the presentation. So we really want to come to the end of this, and we really do appreciate our presenters. So have a lovely evening. Goodbye to all.